Welcome to this explainer. Today, we're jumping straight into the high-stakes, highly modernized protocol for managing acute coronary syndromes. We're going to dissect exactly why those old treatment rules you might have memorized years ago, well, they could actually be hurting your patients today. Managing an abrupt drop in coronary flow is not about just throwing everything at the wall anymore to see what sticks. It's all about precision, strict timelines, and knowing the profound contraindications of every single move you make. Here's our roadmap for today. We're covering 1. The essential triage split, 2. The first 10 minutes, 3. Beating the reperfusion clock, 4. Medication rules and red flags, and 5. Translating all of this to the bedside. Let's get to it.
All right, Section 1, the essential triage split.
When an adult patient presents with a suspected ACS, literally everything hangs on one single binary question. You look right at the ECG for ST elevation. That's your first big branch point. It splits a total occlusion STEMI away from a non-ST elevation ACS. Once you've made that split, then you look at the troponin. The troponin splits the non-ST elevation side into either an N-STEMI if it's positive or unstable angina if it's negative. So lock this pattern in. ST elevation handles the first big split, and troponin handles the sub-branch. Neither the ECG changes, nor the troponin alone makes the diagnosis. You absolutely have to read them together in the clinical context. Moving to Section 2, the first 10 minutes.
There is absolutely zero time for hesitation when that patient hits the emergency department doors. Here are your strict first 10-minute steps. First, get a 12-lead ECG and interpret it within 10 minutes of arrival. If that first one is non-diagnostic, do serial ECGs. Second, draw serial troponins. And third, if they fall into the non-ST elevation ACS category, you need to immediately risk stratify them using a TIMI or GRACE score. Basically, a TIMI score of 3 or higher or a GRACE score over 140 flags them for an early invasive strategy. You're using these scores to figure out exactly how fast you need to get them to the cath lab.
Section 3, beating the reperfusion clock. Let's look at the STEMI side of the tree. If that initial ECG shows ST elevation, you're no longer just making a diagnosis, right? You are racing against a ticking clock. A STEMI is an automatic call for immediate reperfusion. The only decisions left are which method and how fast. The international standard here is primary PCI within 90 minutes of first medical contact. But say getting to a cath lab within 120 minutes is just impossible where you are. You have to pivot immediately. You administer fibrinolysis with a door-to-needle time of 30 minutes or less and then transfer the patient. Hitting these metrics isn't just some ideal goal, it is the standard of care.
Now here's a massive precaution. It's a classic clinical trap that catches people out all the time. Say your patient has a positive troponin and ST depression. Do you give them lytics?
Emphatically, no. Fibrinolysis is for ST elevation only. Giving lytics for isolated ST depression is a hard contraindication unless you highly suspect a true posterior STEMI. A patient with a positive troponin and ST depression has a non-ST elevation ACS. Giving them lytics is completely contraindicated and could cause severe harm.
Which brings us to Section 4, medication rules and red flags.
This is arguably the most critical part of this explainer, the medication minefield. For decades, we were all drilled on the Mona B mnemonic, right? Give everyone morphine, oxygen, nitroglycerin, aspirin, and a beta blocker. While shockingly, treating every patient routinely with that universally drilled cocktail is now recognized as harmful. The modern rules are highly conditional. Most of that old routine has been totally trimmed away because of severe precautions and contraindications.
The one single, unambiguous survivor of the old protocol? Aspirin. It's a class 1 mortality-reducing agent. You must give 162 to 325 milligrams of non-enteric-coated aspirin to everyone at presentation. And this is key, it has to be chewed and swallowed. Giving more than 325 milligrams doesn't help at all, it just causes more bleeding.
Now for the red flags, starting with oxygen. This is a massive shift in practice. Routine oxygen in a non-hypoxic patient is actually harmful. It causes vasoconstriction and literally worsens outcomes. You should strictly only apply oxygen if the patient's saturation drops below 90% or if they are in frank respiratory distress. That's it.
Next up, morphine. It is no longer a go-to. You should only use it if severe pain persists despite maximum anti-ischemic therapy. Why? Because morphine comes with massive precautions. It actively delays the absorption of vital P2Y12 inhibitors, which completely blunts your antiplatelet strategy, and it actually carries a mortality association signal in some registries. So use it with extreme caution, especially in inferior or right ventricular infarctions.
Then there's nitroglycerin. It's great for symptom relief, but the sequence here is critical. Before you even touch it, you have to rule out hard contraindications. Have they used a PDE5 inhibitor, erectile dysfunction meds like sildenafil or tadalafil in the last 24 to 48 hours? Is their systolic blood pressure under 90? Is their heart rate under 50 or over 100? And crucially, do they have a right ventricular infarction? If any of these are a yes, nitroglycerin is strictly contraindicated.
Finally, the beta blocker. The old reflex to push an IV beta blocker is a dangerous trap. Intravenous beta blockers are potentially harmful if the patient has acute short failure, a low output state, or hemodynamic instability. The modernized rule is to use an oral beta blocker, like metoprolol, within the first 24 hours, but again, only after you've definitively excluded those high-risk heart failure signs.
Let's wrap up with Section 5, translating to the bedside. How do we take all these strict protocols, ticking clocks, and severe contraindications and actually apply them on the floor? You need bedside verification pearls. These are the exact screens you and your team must verbalize out loud to prevent severe harm. Before ordering nitro, actively ask the patient about PDE5 inhibitors. If you see an inferior pattern on the ECG, leads I, 3, and AVF, you must get right-sided leads to check for an RV infarct before giving anything that drops preload. And before even considering a beta blocker, you have to actively screen for heart failure.
I love this next part because it's so practical. To prove you're actively avoiding the minefield, you can drop this literal phrasing right into your clinical documentation. ASA 162 to 325 milligrams non-enteric coded administered. Nitro held pending PDE5 inhibitor and RV infarct screen. Recommend oral metoprolol deferred until heart failure excluded. That phrasing perfectly proves you are following the modernized safety-first sequence. You're not just treating blindly. The data is abundantly clear, but we all know clinical habits die hard. So I'll leave you with this final thought to take back to your practice. When that next chest pain patient rolls through the doors, is your team still relying on outdated, potentially harmful Mona B reflexes, or are you strictly following the modernized, stress-tested sequence, respecting the clock, and carefully navigating every single contraindication? It's a question that literally means the difference between life and death. Thanks for joining me on this explainer, and I'll catch you on the next one.